Hello, I'm Alfonso Pinheiro, and today I'm going to be talking about um, complications with the All-on-4 treatment. I'd like to thank Noble Biocare for having me, inviting me to speak on this topic. And this is something that, the All-on-4 has become a very popular treatment modality, and this is something that many patients would love to have. And unfortunately, we do see some complications with this treatment. And today we're going to talk about managing those complications and what complications you can expect. Because this can be a very predictable treatment if we can do that. So we have designed this treatment really to treat edentulous patients, and that was our goal, back when Brian and Mark started looking at implants, and we've come a long way since then. But there's a couple of facts that we need to understand. Today, for example, there's more than 36 million Americans that are edentulous, and 23 million are completely edentulous, and 12 million are edentulous only in one arch. So there are a large number of patients that would benefit from this treatment, and obviously this is a completely different treatment compared to complete dentures, right? And it's a much better patient satisfaction rate. 90% of edentulous patients have a denture. So when we look at the term edentulism, we have to understand what that means, because looking up the definition of edentulism in the Journal or in the Glossary of Prosthodontics, the definition that comes up is the state of being edentulous without natural teeth. And that's the definition. Now, like I said, some options for these patients are a complete denture and an implant-supported overdenture, which is a benefit over a complete denture, or fixed implant prostheses. However, some patients have nothing, and believe it or not, there's a large number of patients that we see that have not worn dentures or anything, have been completely edentulous for years, and they're suffering, and they would benefit from this treatment. No one that I know would love to make a complete denture on this mandibular ridge, right? This is something that no one gets excited about. Oh, I'm going to make a denture on a lower. These patients come in and they need to have a different solution. This patient has already had implants. These are mini implants. They've had an overdenture with those mini implants, and they're still not happy, so they're seeking a fixed solution. Here's another case of mini implants. Here's some locator abutments that have been used. All of these patients are looking for a better solution, and obviously anything that's fixed will have a better patient satisfaction. So here's some poor designs and treatments, but these patients have had failed treatments and they're looking for a better solution. When we're talking about edentulism, when these patients come in and they're without their teeth, they're edentulous. But what happens when we place the implants, right? What happens? Because I would consider this patient edentulous, but would you still consider this patient edentulous? Or this patient? Or this patient, right? I don't consider this patient edentulous. Or any of these patients. Because we've changed the term, we've changed the definition, right? What's the opposite of edentulous? It's dentate, right? And what's the definition of dentate in the Glossary of Prosthodontic terms? Well, it says having teeth or pointed conical anatomical projections of multi-layered hard tissue. Well, we've solved that, right? We have redefined what edentulous is and dentate, because we've given these patients fixed restorations. Now, there's also a different group besides the edentulous patients, and these are the partially edentulous patients, because there's a large number of partially edentulous patients, and in the next 15 years there's going to be more than 200 million individuals. And this comes from the ACP. So that's a large number of patients, right? And what about the patients that are STBE? Now, STBE stands for soon to be edentulous. What about these patients? Well, there's a large number of these patients, and these are the patients that aren't considered in those numbers that the ACP puts out, right? That 36 million patients that are edentulous, or the 200 million partially edentulous, right? 200 million partially edentulous, the ACP says, well, they might need 1 or 2 implants. But what about these patients? These are partially edentulous patients, right? But what else are you going to give this patient? Not many options here, right? Here's another one. Here's another patient that had peri disease, decay, fractured teeth. They're partially edentulous, right? And just looking at some quick cases here. Another patient. This patient has a lot of decay problems, and we can debate on restoring the teeth, extracting the teeth from this photo or from this pano. But when we take a look at the clinical photo, we can see that things are different. When we take a look at the patient's smile line, then the choices are much more limited, right? In order to give this patient an aesthetic result, we're going to have to do something more drastic, and that's going to affect the crown to root ratio of these teeth and probably give them a poor long-term survival. So for this patient, we're going to decide to do all-on-4 treatment. Now, the thing you don't know about this patient is 23 years old. So this is a solution that we have good data on, but we don't have 60-year data on this solution, right? So this patient could potentially live another 60 years or more. So for these patients that are young, that have this decay and this destroyed dentition, we do something that is a little bit different. We place extra implants, we bury them, because by doing that we have a solution. Maybe if something goes wrong with one of the implants, we have some additional implants that we can use in the future. And we do this for our young patients. This is the patient the day of the surgery and the placement of the All-on-4. Another patient, young patient, again, there aren't many options with this dentition. So this patient will get an All-on-4, and for these patients, this is a life-changing procedure, obviously. Now, those are great results, but there are some complications that can occur. And they can occur for a number of different reasons, but these are the top 10 complications that I found that occur. And these are important to know so that you can anticipate it and then hopefully know how to deal with it. So we're going to cover all 10 of these. I'm not going to go through each one right now, but these 10 have occurred, and I'm going to show you some documentation of these. So prosthetic tooth failure, obviously the number one complication that has occurred with hybrid restorations or all-on-4 restorations. And you can see here that the central incisor fractured off, and there's a couple of different ways of failure, which we're going to talk about. But this actually has been reported to happen 40% of cases in some studies. So there's a large number of this happening, fractured teeth, prosthetic teeth. But this happens in 2 different ways, either cohesive or adhesive failure. The cohesive failure is when the tooth breaks off and there's still some tooth in the pink acrylic, as you can see here. Adhesive failure means that the tooth has debonded from the pink acrylic. There's maybe some contamination in the lab, poor bond during the process. And we can see a number of these cases here. You can see that there is, and it can be a combination of cohesive and adhesive as well. Here you can see this is probably an adhesive failure, right? None of the pink acrylic has been damaged. The tooth has come out. So there's probably some adhesive problem there. Here we've had not enough reduction, so there was probably a very thin denture tooth in this area, and we're going to talk about poor design because that's one of the complications as well. Here you can see adhesive failure. This is a cohesive, right? The tooth chipped. So, like I said, something like this can happen in some studies in 40% of the time. Here we have a very large fracture because the denture tooth fractured off, the pink acrylic fractured off, and even some of the opaque layer of the bar has come off, so the bar has been exposed. And this happened over many years. But one of the other complications that occurs with denture teeth and acrylic is that we have more wear. And with more wear in the posterior teeth, you put more load in the anterior teeth. And this happens between the 5 to 10 year mark on many patients, especially if they have an opposing natural dentition. It's a much faster thing, like you see here. Look at the amount of wear that happened here, opposing natural dentition, and look at the amount of wear in the posterior. So they're putting, luckily they're edge to edge here, so they don't have that tipping forces when they're biting. But here you can see a large fracture because there's been some wear, obviously, in the posterior area. So that's the number one complication that can occur. We're going to look at prosthetic screw fracturing because this is also something that can be very prevalent. Well, not very prevalent, but it can happen. And what do we do when this happens, right? You can see one of the screws there is shorter than the others. That screw was still in the abutment. We were able to take the abutment out of the mouth and take this photo. And then we can remove the screw from the abutment outside of the mouth. Luckily, that's an angled abutment, so we have that window. If this is a straight abutment, it's more challenging. And here we have another fracture of a screw. There you can see it intraorally. So again, with that window, this makes it very easy to remove that screw. And you can use an explorer or you can use a wood stick. You can see some projections sticking up from this fractured screw at the most coronal part of that abutment. And if you can stick that wooden part into that sharp metal area, it can help. You can help unscrew it. Here we have this is a video of this is a zygoma implant, and it is there's a screw fracture. I'm using this explorer. There was a sharp piece on the screw where it fractured, and I can use that to help rotate this out. Now there's a certain part where it stops rotating with the explorer, and that usually happens at the last thread. And then what I use here is just a coarse diamond, and I turn it on low rotation, and it helps me grip that screw and rotate it out. So you can see that these screws can fracture. Now, my guess would be that screws fracture most of the time when there's some passive fit issue that has occurred. And because for the most part, we've had great success with these prosthetic screws. One thing that everybody asks is, how often should we replace these screws? And ideally, I'd say replace it every year. However, that is a huge cost for practices and for patients. So there has to be a little bit of thought process that goes into screw replacement. And I look at three things. I look at the threads, I look at the screw heads, and I look at the tightness. These are my guidelines. Screw heads are very important because if you have any wear or any sort of erosion of those screw heads, then you might want to consider removing those screws, because it's happened to me that the driver no longer engages that screw and it's stripped, and now you have to cut out a prosthesis, and that's very challenging and time consuming. So you want to look at the screw heads. You also want to see and make sure that when you turn your screw upside down on a driver, it engages. If it slips off, you're going to want to change that screw. Here's some studies that looked at original screws, which is very important as well. You want to make sure you're using an original screw. A third-party screw, or a fugazi screw as I call it, will have more erosion on the threads when you torque it 3 times. This is torqued 3 times and evaluated under SEM. You can see the amount of erosion on the SEM on the lower picture. There's a lot more erosion, less metal-to-metal contact. That's going to cause more screw loosening, maybe even fracturing. So we want to try to avoid that. We want to make sure that we're using the original screw for the system. A lot of these screws are very similar from different companies. You want to use the original. Here's a study or a paper that was published looking at the prosthetic screws. This is exactly what we're talking about. From 6 months to 20 years, they were able to take these out and look at them under SEM and do a lot of evaluation of these. And what they found was very interesting. One thing that you can see here is on this SEM photograph, you can see that there's some kind of buildup here. This is organic material, and organic material exists in the mouth, it exists in the threads and the saliva. And one of the things that this paper talked about was having that organic material can reduce the screw tightness and the preload. So you want to make sure that if that's happening, you're cleaning those thoroughly. And when the patients come in and we're going to remove these prostheses, we always try to clean these off to make sure that they're clean and hygienic. The one that fractured I showed you earlier, this one had some organic material on it. It has been in use for about 5 years, and you can see the organic material that's built up on it. So these, at this point, can be cleaned or replaced. And in this study that talked about repeat screw joint closing and opening cycles, they looked at this and they wanted to see if there was any loss of the preload. They didn't find any until they tightened it 10 times. After 10 times, they found that there was a loss of tightness. So this is good data because we know that we can torque in and detorque a screw up to 10 times. So what I look at for screw replacement, obviously, number one, if the patient comes in and you're going to remove the prosthesis and you can untighten these screws very easily with your finger, you might want to replace that screw. The screwdriver is not retained by the driver like the video I showed you, and it slips right off. Get rid of the screw. The threads, if you see any damage whatsoever on the threads, you're going to replace that. And this gives you about 3 to 5 years for screw replacement. So again, these are just some guidelines that I use, and in the study that I showed you earlier, there had been screws that had been in use for up to 20 years with no complications or damage. So these screws are very effective. Abutment fracture. So this can also happen, and this happens most of the time with this, the angled abutments. The angled abutments have this little window that you can see on top, and that can distort, it can be damaged, it can be bent or flexed, and you want to make sure that when patients come in that you are able to engage a screw into those abutments. If you're screwing and it's not tightening, you might want to check this part of the abutment and replace the abutment. In one case we did that, and you can see the amount of erosion that's occurred on the engaging part of the abutment, the part that goes inside the implant, and this patient's having a lot of load, so that probably helped to flex that part where the prosthetic screw engages into. But this part can also fracture off. And again, if this is happening, you might want to look at the pacificity of fit of your restorations, because we don't want that to break off. And here you can see from the same patient, two different abutments from the same patient that were removed. You can see the little window here that has been damaged, so that one has to be replaced. This one looks very pristine and clean still. So those are the things that we want to look at when we're looking at the abutments. The other thing I'll mention about abutments, and this goes more with planning, but since we're on the abutment section, we're going to talk about it. How do we select abutments? In my practice, what usually happens is the surgeon will select the abutments, place the abutments, I'll come in and I'll check. And the things that we're looking at most of the time are screw access position, right? So we have the angled abutments, we have the 17, the 30, and the straight. And if the screw axis is coming out the facial of the lateral incisor, we're going to want to use a different angulation to push it behind there, right? We don't want screw access holes in the aesthetic area coming out facial surfaces. So this is one of the main things that we look at when we're selecting our abutments. The other thing is parallelism. We want these abutments to be fairly parallel, even though we have a great range with these multi-unit abutments. We want to make sure that we have a great more parallel, the easier that it is to do pickups, conversions, all of these techniques. So if we can get them parallel, that's our preference. But there's another factor, and this is a factor that I think goes most ignored, and it's the height of the abutments, right? Because we have different heights, and we have 3.5, 2.5, and this has to be something that is taken into consideration. It's very important. I hear many surgeons say, well, in the posterior, I always use 2.5s. That's my go-to. But we have to think differently. Now, one of the things that I've been looking at are the height of the abutments, and we're going to talk about that a little more great detail in a second. First, I'll talk to you about digital angulation, because looking at angulation of these abutments is very important, right? I already told you screw access and parallelism. So we can do this through a digital workflow, right? This is very easy. You can see where the screw access holes are going to come out. You can choose your abutment angulation while you're doing this this design. Or we can do it through analog method, right? Analog, you have your surgical guide, and it's a copy of the denture, and this is where the screw access holes are going to come out, and that's where you want them to be, so you use that as your guide. Again, parallelism is important. We look at that when we're doing these cases, but we have the ability to have great divergence up to 40 degrees with these multi-unit abutments. So we have some leeway there. Now, this is where we have to look and think a little bit harder, because where do you want your abutment margin location relative to the soft tissue? There's no guidance. There's nothing published on this, and no one really talks about this. But I think it's a very important factor that we have to consider. And like I said earlier, if your surgeon is using the same abutment for every posterior implant, then they have to look at these photos, and they have to understand, because we have, sometimes they're too subgingival, and we have these different abutments, we should use them, and we should consider that when we're placing these surgeries. What we don't know is what's ideal, but if we're taking a look at this case, you can see the abutments on the right side of the screen are much taller, the ones on the left side of the screen are much shorter, or vice versa, sorry. The left sides are taller, right side are shorter. So when we look at that, what's your preference, right? So, by the way, this one is a zygoma abutment. So we had some height challenges with that. One of the things that we do for our conversion is we take a final impression of the tissues the day of surgery. And that gives us a working model. And with that working model, we can see where the soft tissue is relative to the abutment margins. And, they look something like this, but this is actually after the surgery, because this is the same abutment as the one on the left. So the only difference is the one on the left was the impression after 4 months, the one on the right was the impression of that same abutment the day of surgery. So this is something that we can't predict. We can't predict where the soft tissue will end up after healing. It doesn't matter if you have the very best digital workflow. It doesn't matter. You can't predict this. Nobody can. So this is why we have to look at this when we're placing our implants. This is completely unpredictable. Many times we're removing a lot of bone, and when we remove this bone, we have a lot of soft tissue left over. We can't predict where that soft tissue is going to end up when it's healed. It's completely unpredictable. So looking at this case, if we focus on this area here, this is the area I want you to focus at, because you can see that there are some metal exposure. What's that metal? Well, let's take a look at the bar try-in. I was taking photos of this case, and I was looking. There probably should have been a change of abutment here, because that abutment is too tall. And today I would change it. But these are things that I wasn't thinking about years ago. So look at the design of the bar. The bar is designed poorly because we have the discrepancy in height between one abutment and the other. So if the surgeon is always using a 2.5 abutment in the anterior, they have to take in consideration the depth of the abutment and the thickness of the soft tissue. So when we're looking at the intaglio surface of these, we want to make sure that we have a nice, flat, and convex surface. We're always disinfecting these as well. But we want to make sure that we want to change this, because if you're looking at this, the prosthesis has to go like this, right? Now we have this area that's going to be a food trap. This is where food is going to be collected. And you can see it here. And that food collection is going to be problematic, perhaps for soft tissues. It's going to be irritating to the patient. On the mandible, we have a little bit more leeway, but on the maxillary restorations, we could have air escape, which could affect the patient's speech patterns. So we want to make sure that we are looking at this closely. We do want friendly contours of the intaglio of these restorations, flat and convex tissues, right? This is a day of surgery with the healing or the impression copings in place, and when we're going to take our impressions. So looking at this tissue, it's going to look very different after 4 months or 3 months of healing, or however long you wait. It's going to look very different. We have to take that in consideration when we're selecting our abutments. Now that means that you're going to have deeper abutment margins the day of the restoration, but we're going to have a better final result. And it's better to do it here than to have the patient come back and do a pickup and replace an abutment at a different height, because that's very time consuming. So when we take these impressions of of the day of surgery, you can see that there's sutures in place. We pick up those sutures in the impression, so the technician will trim the tissues away, as you can see here. They'll trim them, they'll flatten them out, and we can see a difference between the picture on the top and the picture on the bottom. We have a much flatter ridge, and that's exactly what we want, because the flatter the ridge, the flatter the intaglio surface, and the more hygienic. This here is the papilla. We have to get rid of the papilla. That's a huge concavity that's going to exist on the restoration, and if we do it during healing, it's going to be better, because if we try to do it now, the patient can feel that if we're trying to compress that, but before it's reattached to the bone, right, the day of surgery, we raise a flap, we can start compressing this and shaping it that day. So we want to make sure that we're doing that. We want that to be flat like that. That incisive papilla is going to be a challenge. And you can see the tissues as we're pushing and molding them with the provisional. We're flattening these out, and that's exactly what we want to see. We don't want to see this. So tissue compressibility is a term that we've used in dentistry before. We don't use it much, but we've used it for the posterior palatal seal. And we can look at this now and talk about the biomechanics of oral mucosa. There's a great paper on how much compressibility we can put on tissues. Actually, I recommend that you read this. It's a great paper. And it gives you some guidance. So what we do now when we're taking our final impressions is I'm looking at tissues, and if I want to reshape tissues, we're going to do that. We're going to do that with the final restorations, or sometimes we do a prototype. If we're doing a zirconia restoration, we have the patient wear a prototype for 2 weeks, and we can help shape some tissues. But you can see how much and how compressible some of these tissues are, and we can help shape these, right? This big tissue bubble right here, that's going to be potentially a food trap, a bacteria trap. This tissue folds over itself. So if we can help shape that to be more hygienic, it's going to be beneficial. This is a patient I showed you earlier. We've already done some tissue compression on the height of contour of the ridge, so it's not much more compressible at this point. But those are the things that we look at, and I talk to my lab technicians about that. I want to push, remove 0.5 millimeter of tissue moulage, grind it off the model, and that way we can help have these restorations shape these tissues. Subgingival margin. So talking about what's ideal, we still don't know. There's no guidance on this. But would you prefer a subgingival margin that looks like this? This is a hybrid, right? It's got subgingival margins on the palatal and supragingival margins on the buccal. But this is something that we want to try to avoid. And these subgingival margins can be challenging when they're very deep, because when you're removing prostheses, tissues collapse, and then you're trying to put the prosthesis back in, you're pinching the tissues. But we could potentially have more keratinized tissue, because these abutments are more bulky. It's putting more pressure on the tissues the higher up they go. So leaving them shorter could potentially have more keratinized tissue. The other thing to look at is the position of the abutments. I'm going to talk to you about some tissue recession that occurs. And that occurs mainly on the buccal tissues. But what we're doing many times is we're changing these patients' arch forms, because we're doing an ideal setup, an ideal tooth setup, without having to do Lefort surgery or orthodontics. This patient has a triangular ridge, and they have huge buccal corridors when they smile. Well, we want to help to correct that. So the new buccal or the new facial aspect of those bicuspids is going to be here, because we're going to fill in those corridors, right? So that means the lingual of those bicuspids will be here. So the surgical guide will dictate the surgeon to place the implant here. That's too facial, and you're going to have some facial recession. The implant has to be placed. You have to respect the bone and the ridge. The tooth shape and the arch form is one thing, but we have angled abutments for a reason, and we can get away with this. This is a more ideal ridge form. So we're going to be able to put the implants in the exact location, the more proper location relative to the ridge, because that's where the teeth are going to go. But talking about recession here, we see some. And this is 4 months later. The day of surgery, these tissues were tight up against the restoration, the interim restoration, but you can see that some recession has occurred. And you can see that from different aspects. Now the patient has air escape, it's affecting their speech, and they're ready to get into their final restorations, right? But recession can occur, especially on thin buccal tissues. And looking at placing these implants and these abutments more lingually and palatally is a great service, because we can help avoid this, right? Recession occurs in teeth. It can occur on these abutments as well. The other thing is skeletal classification. Sometimes we're changing patients from a class 3 to a class 1 or a class 2, and these implants are going to go into the bone in different locations relative to the teeth. You can see the huge distance between the screw access hole, and this is a class 2 patient. We're trying to make them more class 1, and we're pushing the lower teeth out. Now, this is what we do in the interim. We want to see if the patient can tolerate this, if they can clean it. If we're having challenges, we'll push the teeth back. We'll make more a larger overlap of teeth there. But here you can see when we're correcting these, we have to take in consideration where the teeth are going to go, yes, but we also have to know where the ridge is and where the bone is, because that's going to, we're always talking about restorative driven surgery. Well, we have to still look at the bone. So complication number 4 talks about zirconia copings. We've we've moved more towards zirconia restorations. We still do acrylic restorations, however. I mean, acrylic restorations are great for patients in 80s or older, patients that have a lower all-on-4 against an upper denture, acrylic, right? Why would we do zirconia there? So we still use a lot of acrylic, but younger patients, 50s, 60s, zirconia is a better restoration because we've eliminated a lot of fracturing, right? This is a study that looks at fracturing, and what you have to take into consideration is cantilever length. The cantilever length is much shorter than it is with acrylic and metal. So we don't want to go over 12 millimeters of cantilever. And if it's not thick enough, it can also fracture, as you can see here. So we have to have proper design. We're going to talk about that a little bit later. But I want to talk about the way that the zirconia fits onto the multi-unit abutment. Traditionally, or at first, what they would do is they would just mill the zirconia, and the zirconia didn't have any titanium insert. It would go straight onto the multi-unit abutment, and it would do great damage to the multi-unit abutment. So in order to correct that, they started to put in these titanium inserts, and these are bonded in place. Here's one that debonded, and we want to look at why this debonded. You can see it's a short titanium coping that was bonded in place, so we'd like that ideally to be longer. The other side of this had a fractured screw, so we might start thinking about maybe there's some passive fit issues. And this abutment, if you take a look, this coping, this titanium coping that's bonded into the zirconia, we're going to take a close-up look at that. If you see that, it's not even seated, right? It's not even seated in the zirconia, and there's a problem because this is going to throw off your entire restoration. If these aren't seated properly, then you're not going to have a passive restoration because these are milled, right, through CAD/CAM. The zirconia is milled. It takes into account that titanium coping height, and then you bond that in place. If it's not seated all the way, you're done. You've thrown this thing completely off. It should look more like this. So the labs have to be very careful when they're bonding these in place, right? Here's another one. This patient had some irritation around their titanium copings, right, around the implants. Well, this is a lot of excess cement. I used to talk a lot about excess cement. I'm talking about excess cement again. And this is a problem because this patient actually had a methacrylate allergy. They couldn't wear methacrylate prostheses. We put them in zirconia. And now they have irritation because there's a bunch of methacrylate resin cement contacting their tissues. So this has to be cleaned up. Now, if we were going to look at plaque retention, and we're going to compare plaque retention between acrylic, titanium, and zirconia, which one do you think retains more plaque, right? If you had to guess which one retains more plaque, you would probably say acrylic, and you'd be correct. Zirconia, the least, right? How do I know that? There was a study that was done at Baylor by my good friend Francisco Curiel for his thesis, and he found that zirconia retains much less plaque than the other materials. And that was a great, study to look at that. However, one thing that was noticed was that there was significantly more plaque retention around the implants. And that was something that, was questioned. But why did that happen? So if we take a close look at, this is a zirconia monolithic restoration. These titanium copings have been bonded in, and you see a void. You see a big void there, and a channel. And you see that here too, that channel that exists. That channel exists because we want to make sure that this is seating passively. And the way that this is bonded in is that these titanium copings are screwed into the model, and then the zirconia is seated onto the model with resin cement, and then it's cleaned up. But they make these channels so large because they want to make sure that you have the right room, the proper room and cement loot space and all of these things to make this predictable. But then these channels act as a food trap and a plaque trap. So what we do is we seal them. I use a Fisher sealant to seal these. You can see all the voids that exist here. Look at the voids. Look at the food accumulation, the plaque that's accumulated here. So we have to clean that out. There's a huge mechanical lock in this area, so we just flow in some sealant material. This is Fisher sealant. And the reason that I use Fisher sealant is because when you light cure this, it's highly polished. You don't have to go back and polish it. You flow it in, and it's already highly polished, it's tissue friendly, and it's very easy to use. Now, there's been some great studies on survival of zirconia restorations. This is one that was done in Connecticut by Beeder's group, and they looked at great results from the zirconia. So this is becoming a more popular restoration by far. This is a far more popular restoration than acrylic. It's much less complications, right? If we have teeth fracturing off acrylic restorations 40% of the time, then this is the solution to that, right? And the wear rate is less, and there's less plaque accumulation, more tissue friendly. So we're seeing a much larger trend of going towards monolithic zirconia. A complication that can occur, number 5, is implant failure, right? And I see this as a domino effect. I had a patient that came in, and they had they came into their surgery, and I wanted to see them 2 weeks later, and they said, well, I'm going to Arizona for 3 months. I go to Arizona every winter. And they never told anybody. They didn't tell me, they didn't tell the surgeon, so they left. And they came back, and he started telling me about everything's great, except it's a little loose. I said, okay, what do you mean it's a little loose? Yeah, it started getting loose. But it didn't stop me from eating, my favorite. I love this bean dip and these hard tortilla chips that I'm eating every day. And I looked, and what happened was the implant on the posterior right, upper posterior right, came right out. I took the prosthesis off, the implant came out. The next one over, I had to use some forceps, I took it out. The next one over. So it's like a domino effect, right? You have something that's loose, it's failing, it moves, it affects the next one, and the next one, and the next one. And so I learned 2 things. Make sure your patients don't leave for the winter. If they do, make sure you know that. And, we tell the patients if you feel any looseness, but some patients don't listen, right? But it can be something that looks like this. We have great implants here and great stability with these implants. However, through a number of factors, which we might never know, these failed. And the 2 anterior ones failed. So we had to place 2 different anterior implants, and later we're able to give this patient a final restoration and just still use the posterior teeth. Luckily, these implants came out, the 2 new implants went in, we were able to pick it up on their interim prosthesis, so they were never without teeth. Another implant failure that can occur is a fracture. This is not common, but it can occur. This patient fractured all of these. And actually, obviously this is a different type of force that this patient is producing in their mouth. We have these patients that have force levels that are off the chart. We can't always know that ahead of time, right? Poor maintenance. So maintenance is one of the most challenging things with these restorations. And if anybody is not a fan of the All-on-4 restoration, they'll always say, well, you can't clean these. So you can clean them, and we're going to talk about how we can do it. So we're going to look at the hygiene protocol that we have. Everybody has pillows, and all of the pillows have this tag on them, and it says, do not remove. And for many times, I would talk to people, I would hear them say, you don't remove these ever. You just leave them in place. Well, I don't agree with that. You have to remove these, right? You have to remove these. Now, how often you remove them is something that we can control and that we have to plan for. And how do we plan for that? Well, we know we're going to remove these restorations, especially the temporary restorations that these patients are wearing, at least 3 times. When we're going to take our final impression, when we're going to do any sort of try-in, it can be a wax try-in or a milled try-in or a bar try-in, right? and when we're going to do a final delivery, for example. So this is just a video showing, I used to put composite in the holes, but now I don't do that. I put Teflon tape on all of these, and then I use a material called Fit Checker, which is just a silicone, a VPS silicone, you know, it goes in fairly quickly. You can see we put Teflon tape to protect the screw heads, and then we're going to just flow this over the screws, and you just wipe them off. That's it. Then when the patient comes back, it's a very easy removal, and it comes off with the Teflon tape attached. And that saves a lot of time, right? Because we know, patient, we just took a final impression, we're going to put this back in, we're going to see you in a month or in 2 weeks to do a try-in. And this is when we remove it, when we do our evaluation criteria. We want to make sure that we're looking for things like gross accumulation of calculus, right? We can see that sometimes without removing the restoration, right? But when you remove it, you can find much more problems, like you can see down here. So this patient is going to have always this accumulation. Poor hygiene. Some patients do better than others, right? We can see this patient doesn't do so great. We can see some scrambled eggs from Easter there. So this patient has to have some more instruction and some more motivation to clean this, right? And persistent tissue irritation. So anytime we see tissue irritation, we're taking off a restoration, we see tissue irritation, we note it, and we check it the next visit. And we want to make sure that it's improving. And we do different things to improve it. We might recontour the interim. We might put this patient on some rinses. But we want to make sure that that irritation is improving. Now, when we look at these patients and we see that evaluation criteria, and they have that calculus that is just produced in weeks, we want to see this patient more often, and we put patients in different groups. We have 3 groups. We call them recall frequency groups. Group 1, we want to see this patient every 3 months. We remove the prosthesis 2 times a year. So we see the patient 4 times a year, we remove it 2 times a year. If we have any improvement in tissue irritation, in calculus accumulation, or hygiene, we can change the group of this patient and put them in group 2, which we see every 6 months. And here we remove the prosthesis once a year. We see them twice a year, we clean, but we only remove it once a year. And group 3, we see this patient once a year, and we might not remove this prosthesis because there's a large number of patients that do great with this restoration, they do great with hygiene, and we don't have to remove this. If we have a patient, and group 3, you just don't put a patient in group 3. You put the patient in group 2, you've taken this thing off, and it looks clean and pristine, you say, okay, we're putting this patient in group 3. We see him every year. If we see anything, tissue irritation, or there's challenging cleaning, or anything, we'll remove it. But for the most part, we can maintain these without removing them on certain patients. Again, this patient we're going to want to see more often, right? Because they're going to have a problem. Now, what instruments do we use? When we are removing these, we can use some instruments to clean the abutments. We want to make sure that we're removing any calculus, debris that we have around there. And there's a number of instruments that exist. You know, we've been trained to use plastic instruments for implants for years. Now we're moving more towards titanium, right? Plastic and titanium. These plastic instruments, these titanium instruments, are implant specific. What makes them implant specific? Well, they're made out of plastic or titanium. They're not made out of stainless steel like the other instruments that are made for teeth. So just making any instrument that was designed for teeth into titanium now makes it implant specific. I have a problem with that, right? This is an implant specific instrument for cleaning. It's made out of titanium, but it's a Langer curette. Langer curettes were developed for teeth, not for implants. Why are we using the same shape for teeth that we're using for implants? Here's another one. There's a Langer set here. They have a Langer 3-4. And it's implants, right? Because it's made out of titanium. If we look at the Langer curette, Langer curettes were developed many years ago by Bert Langer, and, they were designed for teeth. Teeth that have CEJs, that have different embrasures, that have different sulcus. And this is not meant for implants, right? Because that looks nothing like this. How are you going to use that when you're cleaning something like this? So we had to come up with something different, and this is what I designed. I designed an arch kit. This is the only kit that is designed for hygiene of all-on-4 restorations. And it's different because it's designed for implants. It's not designed for teeth. It's only designed for implants. And it looks something like this. There's 4 instruments in the set. And the first thing that I had to do when I was designing this is I had to break all the rules, because there are some formulas for instruments that when you're designing the instruments that you have to use. We have to break these, because these, Black's instrument numbering formula, that's for teeth, right? Not for implants. So we have a different shape here, completely different shape. I worked with PDT. PDT is a great company out of Montana. Their most popular instrument is the Montana Jack, which I love and I recommend that as well. I think it's a great instrument. They have a Jack B. Nimble instrument. So they have a lot of great instruments. But they also have a great titanium for implant restoration, for implant maintenance. But working with PDT, PDT is a company that works with a lot of hygiene instruments and hygienists. And when I'm designing this instrument, they're like, do you want to include a sharpening stone? No. We don't want a sharpening stone. This is for implants, right? We don't want sharp instruments around our implants. So we don't want a sharpening stone. In fact, I don't want any sharp areas on any one of these instruments, right? So you can see the difference between our instrument, which is a completely different shape, only for implants, and a competitor that is an implant-specific instrument, as they call it, but it was designed for teeth. They just made it out of titanium. The difference is this implant is semicircular. It's an arch shape, right? And it can lock onto components like this. It locks onto components and it gives you more freedom for rotation, for up and down movements, and you're not slipping. A hygiene instrument, when you're trying to clean a circular component, can slip and then the patient says, ow, right? So this is the Pinheiro arch number 4. Actually, this is the only sharp part of any instrument that we use. Now, this looks like a sickle curette, and many hygienists are most familiar with sickle curettes, so they always want to use this instrument, but this has a very specific purpose. You can also see the flat design. It doesn't have any sharp edges here, because this is meant to go in between the prosthesis and the tissues to clean. That's why it's flat. This sharp edge is used only if we have some calculus or we have to debride around the teeth, because when we have teeth in acrylic or even in zirconia, we have some deep areas there, and you can get any debris out with that sharp edge. That's the only reason we have that sharp angle. Now, this is a multi-unit abutment replica, and it is, you can see the diameter of this matches that. Now, the great thing about it is it matches a multi-unit abutment. It matches the abutments for this type of treatment for every company because they're all the same. So it locks into place. And it also increases our surface area contact significantly, right? Because it engages a third or a quarter of that abutment. And here, even if you turn this on its side, you're still getting very limited contact. So we have great surface area, and the surface area helps us to be more efficient with cleaning. It also helps us to reduce any scratching to our components, right? That's really important. So on the left, it's designed for implants. On the right, it's designed for teeth. And like I said, there's 4 instruments in the set. The Pinheiro Arch 1 is for anterior. This is the first one you're going to use. You're always going to start with the anterior because we're going to focus more on the anterior implants because that's usually where we're going to have the most calculus buildup and plaque buildup, and especially lower lingual. So this has the right curve of the shank in order to give us the best access to this area. And we can go in and clean that very efficiently. Now here you can see some blanching of the tissue. That is the design. This is there's a flat bottom and a flat top, so you can push on the tissues. But with that large surface area, the patient isn't saying, ow. It's not cutting them, right? It's not hurting. So you can push tissues out of the way and gain access. Remember, tissue compressibility? These tissues can move in this area. You have great access to this. On the lingual, this is more challenging, right? Because sometimes we can't see where that component is. It doesn't matter. We can see where the screw axis is. The screw axis is here. You line this up with the screw axis, it will engage onto the component. It's the same diameter, right? Or has a similar diameter. It'll engage, you know where you're on the component, and you can rotate, go up and down, and debride that very efficiently. This is with the restoration removed, and I'm just showing you up and down. We just clean that off. You rotate around. And here we're removing some calculus. Right? Very easy, very efficient. The Pinheiro Arch 2, so you start with the anterior implants, both upper and lower, and then you go to the posterior implants. And with the posterior implants, you use the Pinheiro Arch 2 because it has the right design. Here we're keeping and you can get access from the lingual, from this. These are two-sided instruments. But you can see I'm just rotating this. My camera girl was a little drunk, I guess, this day, so she's going to go out of focus here for a second. But you can also turn the restoration and go under the prosthesis like this. Right? And I'm cleaning out the flange of that prosthesis very efficiently. And it has the right shape. And now I'm engaging the component. Look, I'm pushing the tissues out of the way, and there's no discomfort from the patient. Pinheiro Arch 3 is used for, these are harder to reach areas, so this just has a very slightly different angle, but mesially and distally, this will help you to get in those areas. And subgingivally too. So if you do have a subgingival margin, you turn the instrument on the side and you can get underneath those tissues. And this is the Pinheiro Arch 4. Like I showed you earlier, this goes under the restoration in between the tissue. It has a flat edge, and you can engage it. It has the same diameter of the multi-unit abutments and the framework, so you can use this to clean that very efficiently. You can see here, this is just showing you what it looks like removing the restoration, right? This patient has a lot of buildup here. That's why we removed it. But I wanted to show you, you can slide that restoration under there and do the same thing, because it has a flat edge. This is from actually a hygienist. Now, like I said, hygienists have a preference for certain instruments, and they want to use this curette because it looks like a sickle curette, and they're very, comfortable using something they're used to. They're not used to using an implant-specific instrument. This is not how you're supposed to use this instrument, but they're using, and actually this is the patient's husband, and you can hear him say ow a couple times. But again, this is not for the number 4. This is for the number 2. We're in the posterior area, and you can get under the flange with the 2 much more efficiently. And that, remember, this number 4 is the only one that has the sharp angle, so you don't want to use it that way. But remember the recall frequency groups. Obviously, a patient like this is group number 1. Right? Because we're going to want to see this patient with this amount of buildup that occurs. We're going to see them much more frequently. And here's a video just removing some buildup here very efficiently, just rotating that instrument and cleaning that all out. Look how easy that comes off. Because we have the right design, we have the right surface area of that abutment. And here we've moved on. I left all the excess there just for dramatic effect. I promise I go back and clean it. But we can go back, and I'm just going to Look at how I can get under the tissues there, even this way, and I can push the tissues out of the way, and I can get subgingival very easily. There's no blood, there's no bleeding, and this is how we clean up these restorations. I was very honored to be nominated for the Edison Award for 2020 for Best Product Introduced into Dentistry with this kit. And so it's been a very fun ride working on this kit and developing it. So I'm just going to share this video.
Everybody got somebody to lean on.
And here you can see we're finding where that lingual abutment is by feel, rotating. And we're going side to side, we're pushing the tissues out of the way. So, we're going to move on to abutment screw fracture. And this happens sometimes, right? This abutment fractured. It's deep in the implant. And luckily, this is a straight abutment and not an angled abutment, because that would probably be more challenging. But I was able to get this out with the same technique I showed you earlier, very, very carefully using an Explorer, screwing it out, and then going in with the diamond and getting out the rest of the screw. Very deep tissues, but this is more challenging because we don't have a little window to get these screws out, but that can happen. Biologic complications also can occur. This is some bone that is exposed, patient's in pain, so we have to go back, remove that. When we remove that, we're going to have more exposure of that abutment. We might want to change that abutment out, right? And here we have some bone exposure as well. And the patient was, I had to numb the patient. I actually did this myself. I don't do surgery, but I did this one because my surgeon was not around. So I just give them a little bit of numbing, and you can see the bone is above the abutment. What happened was that this piece came off, and now you can see the huge deficiency in the tissue there, or in the contour. And the bone that came out looked like this, but I think what happened here was that buccal bone fractured off. You can see the bone has imprinted into the abutment. Do you see how that has imprinted into the abutment? Maybe when we torqued that abutment in, because it has a wide base, it kind of broke that buccal bone off. Something like this can happen, fractured jaws, thin jaws, when we're putting implants in these areas. Very, very challenging, and we want to make sure that we are talking to patients. This patient had these implants placed. A few weeks later, she suffered a jaw fracture, so this is a challenging case. You've all had drinks out of styrofoam cups, probably not as much anymore, but there's also something that I call styrobone, not styrofoam. But this is very, very soft bone. And these are patients that we can't, unfortunately, load the implants that day because it's so soft. We have implants that go in and the torque is 10 to 15 Newton centimeters, and we feel more comfortable not loading those implants at that point. You can't always see styrobone on a CT scan, so sometimes it's a surprise the day of the procedure. Poor design is another complication, and this is something where we have to look at, how we're designing our restorations. And when we're designing titanium acrylic, we want, an abutment height we could use up to 3.5, right? That's the minimum. And the bar can be 5.5, so we have about 15 millimeters from the bone to the occlusal plane. And 3, I like to have nice thick acrylic. The thicker the acrylic, the more the denture tooth is in the acrylic, the less debonding will occur and it will strengthen it, right? We talked about debonding of teeth earlier. If we have not enough reduction, this is where the design comes in. If you don't do enough reduction and you're doing a titanium and acrylic restoration, the first thing that technicians will skimp on, dentists will skimp on, is the acrylic. You can see here that the tooth came out and the titanium framework is exposed because there wasn't enough acrylic in between the tooth and the framework, right? So that's very thin. And it looks something like this. So when you don't have enough reduction, the acrylic will be thinner and it won't support the tooth as well. Now with zirconia, it's different. Same abutment height. Now we have the titanium coping. We want that to be at least 4 millimeters tall. And we want to make sure that the the thickness of the zirconia is between 8 to 12 millimeters. I already told you we don't want longer than 12 millimeter cantilevers on the posterior of the zirconia, right? 15 is too long. We want to keep it at 12. And by doing that, we've had very little complications with zirconia. And that's one of the studies that I mentioned earlier that Beedra did, looking at those parameters. With acrylic and titanium, we have the AP spread. This is just a guideline. It's not a great guideline, but the more anterior spread that you have, I think it's a better restoration for patients, right? You can have that with 4 implants. You can have that with 6 implants. If you're doing zirconia, you want 6 implants, because the other thing that you don't want is between the screws, between the abutments, you don't want more than 20 millimeters. That can weaken that. So if this is going to be zirconia and this patient has a very large ridge and a large maxilla, you want to make sure that you're placing a couple extra implants there. And the last complication, and maybe the most challenging, is the patient acceptance, right? Patient acceptance is, in everything that we do aesthetically, is very challenging because we have some limitations, maybe with communication, maybe with patient expectations, right? This patient wanted a new restoration and the shade was a little off. You can see that, right? This patient was very aware of that and we had to match that a little bit better. But we want to make sure, one of the most challenging things is midlines in these cases, right? We want to make sure that we're communicating with that lab, with the lab. These are some photos I take and some instructions for the lab from a setup that we're doing where I want the teeth to be. This patient came in and she didn't like her midline. She said, my midline's off and it shifted to the left. So when we show her these photos, so I sit down, I draw this photo for this patient and explain that, we're looking at the middle of your face. You have some asymmetry in your face, and that's why it appears. If you want, we can change it. But once they see this, they get it. Okay, yes, I get why you put the midline there. But then she says, but my occlusal plane is off. And I'm like, okay, the occlusal plane, your teeth are slightly thin. Her lower lip goes in a different direction than on the left than it does on the right. So that's what she's seeing. And, we look at the interpupillary line. I draw a line. I explain this to the patient. These photos are very, very informative for patients, so they understand why and how we do things. Once they see that, they're for the most part, they've been very pleased once we show them these things. But we want to make sure that the midlines are where we want them. We draw photos for labs. This is for lab communication. And if we have, we want to change the flare and the incisal edge, we can take photos and communicate that. If we just want to change the trajectory of the midline slightly, right? If it's a little bit slanted, then I'll draw a photo. The blue is the current trajectory. The red is the desired correction. The lab can then see that very slight correction that they have to make, and they're able to implement that. So the last thing I'll talk to you about is night guards. And night guards for every patient, right? We give night guards for every patient, and sometimes we make multiple night guards. This is very important for these patients and trying to get them in the habit of doing this. If you can get them in the habit of doing this in their interims, then you'll have much less fracturing, much less teeth popping off. And then they'll just continue that habit. So those are the top 10 complications with all-on-4 restorations. The other thing I'll just mention, because I don't think I went over this, but we're talking about the height of the abutment and where we want that to be. We don't know. My preference is to have it at or slightly below the gingival level. Predicting that is the challenging part, right? Predicting where that is going to be is the most challenging part of having that success, because again, we don't know where the tissues are going to heal to, and you might have to change out some abutments to get a better final result in many of these cases. So we have to have more studies on the tissue that the tissue healing that occurs specifically with all-on-4 restorations. We know a lot more with single implants, but with this, when we're doing alveolectomies, it's unpredictable. We need more guidance on that. So I'll leave it there. I'd like to thank you very much. This is my email if you want to contact me, have any questions. I'll just say that the instruments are available through Henry Schein and Patterson and all of the distributors. I'm open for questions, and I thank you very much. Thank you to Noble Biocare. Sorry, I'm just going to switch that. So one question that we have is, I found one of my all-on-4 implant failed. What should I do? What's the best treatment for this kind of complication? Thank you. So there's a lot of variance here, because is it one implant that failed? Is it multiple implants that failed? Sometimes that occurs. So I would say that if it's one implant, what you have to do is find bone, right? So when that happens for us, we keep all of the interims. If they're still in their interims, then it's easy. You take out the implant that's failed, you place a new implant, you seat the interim on the other 3 implants, and you pick up the new position of the implant in the patient's mouth on the interim, and you have that heal, right? If it's multiple implants that failed, you have to look for bone. You have to look. I showed a case where 2 anterior implants failed. We were able to find bone in other areas. So it failed. Luckily, these are almost all the time early failures, right? And they're in their interims, or they've just worn their finals for a year, right? Or less. So sometimes you have to use the final to do a pickup, but you just have to be able to do that. Next question, concerning patient acceptance, what is your experience with double arch zircs, clacking of teeth? I don't hear that complaint that often. When I do hear that, one of the things that I've noticed is that different zirconias have different sounds. We use Prey-Tau. It's a very, it produces a less clicking sound. Some of them sound like you're doing cheers with glasses, right? This type of zirconia is less audible. So there's a big improvement with that. And some people say my teeth clack, and I say, look, I can clack my teeth. I have natural teeth, right? So they just have to understand the limitations of the material, but it's not really a big issue. Next question, my friend Filippo Cangini. I don't know when I'm coming to San Francisco, maybe when Corona's over. The next question, restorations, you showed 4 implants with zirconia restoration. What is rule Y6? There's no real great rule with this. This has to do with arch form, arch size, distribution. What we know is we don't want 20 millimeters between each implant. So if you have a patient with a large arch and had large teeth, you might have to place more implants in there. And we don't want cantilevers more than 12 millimeters. So that's the guidance, right? If you have a patient with a small arch, you can put 4 in there. You probably will have less than 20 millimeters between each implant, and you'll be able to go to the first molar. If you have a patient with a large arch, sometimes the inter-implant distance with 4 is over 20, so you're going to have to place an implant here and there in between. The next question is how to manage labially flared mandibular fixtures for all-on-4 restorations to determine if they can't be used for restoration. Thank you. I don't know how to manage labially flared mandibular implants. Labially flared mandibular implants, we try to tilt them as lingual as possible. If they're too flared buccally, we will use a angled abutment to push the screw access back. A lot of patients that we see, the majority of the patients that we see have a class 2 occlusion. And so labially flared implants are kind of okay because we're trying to make them more class 1. Having them labially flared will help us push the teeth anteriorly. And I think that's all the questions for now that I can see. Let's see. Did I answer all of them? Any questions? Yeah, so I think that's all the questions. I hope I've answered your questions, and thank you for joining us. I hope you have a nice evening, and everyone stay safe. Thank you.